So, welcome first of all to you all this afternoon. My name is Ivor Smith. I'm the Managing Director of Shabo Biotech, and what I want to do in the next 15 minutes is basically run you through some of the evidence for why fecal tumour M2-PK is an improvement in colorectal cancer testing. Apologies for the fact that this presentation was due to be given by Dr. Ruth Ayling. She's actually been off unwell recently and so wasn't able to fill the particular slot available to us today. Want to first of all start by talking just a very little bit about M2-PK and its role and position in tumour metabolism. Essentially, pyruvate kinase, which is what the PK stands for, is a key enzyme in glycolysis, and under normal circumstances you get multiple isoforms which are tissue specific, and all of those isoforms are actually tetrameric molecules. However, in tumour cells, M2-PK is predominantly present in its dimeric form, and as the dimer is usually referred to then as tumour M2-PK. Just to look at the various tetrameric isoforms, you have LPK in liver and kidney, you have M2-PK in lung proliferating cells, tumour cells, adult stem cells and embryonic cells, for example, and M1-PK, which is available in the muscle and brain, is essentially then also involved in energy production. If you look at the tetrameric form of M2-PK, the normal pathway there is that glucose is converted through to pyruvate, and that then goes on to lactate with the production of energy from ATP. And the tetrameric form is highly active for its substrate of phosphoenol pyruvate. However, if you then look at the situation for the dimeric form, then there is a very low activity in the interaction between tumour M2-PK and phosphoenol pyruvate, with the effect that you get a build-up of nucleic acids, phospholipids and amino acids as the building block then for cell production. Tumour M2-PK is basically then shed from the colorectal tumours into the GI tract and can be measured in the stool of patients. Using a sandwich ELISA, which has antibodies that are specific to the dimeric form of M2-PK, then you can detect this as a marker, primarily for colorectal cancer, then in a fecal sample. One of the initial studies that was first published was by Hart in the British Journal of Cancer in 2004 in a cohort of about 200 patients who'd received colonoscopy using a cutoff of 4 units per mil. Then the overall sensitivity was 73% with a specificity of 78%. And they also identified that there was a strong correlation between the increase in fecal tumour M2-PK levels and increasing Dukes staging, so that the sensitivity of 60% for Dukes A, so early cancers, increasing to 90% for Dukes D, so a late stage of colorectal cancer. A further study, which is then a UK study from COS, published in Colorectal Diseases in 2008, looked at fecal tumour M2-PK both before and then in a subset after surgical intervention for colorectal cancers. They used a cutoff initially of 3.33 units per mil, which was twice the upper level of normal in their particular patient cohort. And with that cutoff, then their sensitivity was 91% for colorectal cancer, 60% for polyps of 10 millimeters and above, with a specificity of 92%. If they then applied the conventional cutoff that had been used elsewhere and is generally used for 4 units per mil, then the sensitivity decreased a little to just over 80%, but as you'll see, that's compensated for by an increase in specificity. Looking then at measuring fecal M2-PK after the surgical removal of the tumour, then in 6 out of the 12 patients that they followed up, the tumour M2-PK levels fell below the cutoff. In the remaining 6, it's interesting to observe that of those, 1 patient actually had local colorectal cancer recurrence, 2 of the patients had colorectal polyps at the time of their follow-up, and 2 of them had rectal abscess. So in 5 out of those 6 cases, there were specific reasons that would then result in an increased level of M2-PK in those patients. Looking then at the next study, this is actually an Irish study from Professor O'Moran in Dublin from 2005. They also looked at fecal tumour M2-PK and compared it with the guaiac FOBT. What's particularly relevant about this study is that these were primarily asymptomatic patients, whereas in the previous studies they'd looked at patients with a symptomatic presentation. The sensitivity for colorectal cancer in this particular patient cohort was particularly high, with a sensitivity of 97% and a specificity of 98%. For adenomas, particularly also notable that they had a sensitivity of 76%, and that sensitivity for both colorectal cancer and for adenoma was substantially greater than seen, as one might expect, for the guaiac FOBT test. The next study is presented or was published from a German group, patients recruited from the colorectal cancer screening program in Germany, which essentially is focused around colonoscopy. So all of these patients had a total colonoscopy performed. The thing that I wanted to draw your attention to from this particular study is that whereas the overall sensitivity of 78%, then you can see that there's actually a substantial difference between the sensitivity for colon cancers with 91% compared to those for rectal cancers with just under 60%. The reason for this may very well be that in the case of rectal cancers, when the cells are shed into the GI tract, there's not then as much time for those cells to be freely and evenly distributed within the stool before the stool sample is taken for assay for fecal tumour M2-PK. And once again in this study they showed a correlation between staging, so a lower sensitivity of around 60% in early colon cancer, rising up to 90 to 100% as far as the late colorectal cancers were concerned. This just presents then, from a different study, that association with the stage of cancer in a graphic form that perhaps may be a little easier then to follow, but essentially the same pattern that we'd seen in the previous studies. The next study I present to you partly because of the large number of the control, large number of controls in this cohort, and they were in the age of 50 to 75 years, so essentially the right age group for colorectal cancer screening. And again, we see here that the level of sensitivity for colon cancer, as we'd seen previously, is quite a bit higher than that for the rectal cancers. In this particular group, because they were a rectal cancer specialist centre, then they had far more rectal cancers than you would normally expect to recruit into this kind of study, and therefore the overall sensitivity of 79% was after they'd corrected for the much higher proportion of colorectal cancers within their particular study, and again specificity around the 80% mark. This provides you with a quick overview. I'm not going to dwell on it because we don't have sufficient time, but basically the mean, as you will see, for the sensitivity is around about 80% out of all of these studies, and that's based on around 700 colorectal cancer patients. Again here, looking at some means from the published studies, you'll see once again that, as we'd seen before, around 60% sensitivity in T1, so early colorectal cancer, rising up to 90% as far as the later stage cancers are concerned. And it's important in some of the studies to at least have a true healthy control group. And here you can see patients who had undergone full colonoscopy that was negative. The specificities there are of 93% and above. That's then borne out by a further study which was looking at nearly 5,000 company employees in Germany who were offered fecal tumour M2-PK testing, and based on the prevalence for colorectal cancer that one would expect in their age group, then the estimated specificity was a specificity of 93% for tumour M2-PK. And that fits in quite nicely with a different study that was done with around 3,000 individuals being invited for a screening program, where just over 8% of those patients had tumour M2-PK levels, fecal tumour M2-PK levels, above the cutoff of 4 units per mil. Also illustrates that if you increase the cutoff level and perhaps take 6 units per mil, for example, then only around 3 or 4% of those patients have then an elevated fecal tumour M2-PK, which shows that you do have the flexibility in terms of cutoffs if you're looking at a national program with specific financial considerations as well that need to be complied with. Overall, the specificities from the studies published to date, and that's based on over 10,000 individuals, which I think is a substantial number, is around 92%. One of the things that can actually increase tumour M2-PK levels is also then very acute inflammatory bowel disease, for example. Those would be counted as being false positives in a colorectal cancer screening cohort, but of course that's a worthwhile additional diagnosis to make if that irritable inflammatory bowel disease was previously unrecognised. I'll skip over the next one for the purposes of time, but just to say then that for the fecal tumour M2-PK, it is available as a commercial validated test kit, which is CE marked and is a fully quantitative ELISA, and the quick prep device that some people may be familiar with from the use with fecal elastase can also be applied in this form for ease of sample preparation as far as the fecal tumour M2-PK is concerned as well. So colorectal cancers primarily are the cause of an increased level of fecal tumour M2-PK, although as we said there may be other GI diseases which will also result in that increase. Only a very small stool sample is required, and that stool sample is stable for around 48 hours or more at normal room temperatures, so that enables the sample to be conveyed from the patient and reach the laboratory. Cutoff that's generally applied at the moment is 4 units per mil, as we'd said, and those patients who have elevated fecal tumour M2-PK levels should be further investigated for a definitive diagnosis, and in the majority of cases that's going to be confirmed by colonoscopy. Just to summarise at the end, I want to run through for you some of the benefits of using fecal tumour M2-PK. It's clearly a non-invasive test. There is only the need for a very small walnut-sized stool sample. The requirement is for a sample just taken from a single stool passage, a formed stool, so you don't need to have multiple days of stool collection, nor do you have to have collection from multiple stool passages, so that has an advantage as far as the patient is concerned in terms of ease for the patient, and therefore that should be seen in terms of improved patient compliance. And as we'd said before, with the stability at room temperatures, then the sample can actually reach the laboratory through the post, amongst other methods. Tumour M2-PK, because it's a metabolic activity marker, is also independent of bleeding from either the tumours or polyps, and that means that it has the ability to pick up non-bleeding lesions. There are no pre-test dietary restrictions, so again that makes life easier as far as the patient is concerned. And because it's independent of genotype, then it means that it's applicable to a general population screening. It's not restricted to one particular part of the overall population. The high sensitivity that we've presented to you earlier basically means that there will be less missed bowel cancers, and that's obviously a major advantage and of importance as far as the patient is concerned. And the fact that tumour M2-PK may be elevated in other colonic diseases also means that it may help in picking up previously undiagnosed or undetected ulcerative colitis, Crohn's disease or diverticulitis, for example. And from a patient's point of view, then that also has to be seen as a positive. Just in terms of cost, just to give you a feel, at the moment the costs are around £10 per test for the fully quantitative ELISA. That's based on the current relatively low numbers of samples that are being assayed this way. There could very well be future economies of scale if those numbers were to escalate dramatically. And there is also an independent send-away service available at the moment at the Derriford Hospital in Plymouth. So there is access to testing for fecal tumour M2-PK at the moment. Just a couple of websites to finish on that may be of relevance. The first one focuses very much on the metabolic aspects if you want to get further details about that for tumour M2-PK. And you'll also find some additional details on our own Shaber Biotech website. So we tried to run through quite a bit in a short period of time. I'm now open to questions. I can also make available to you the slides after the presentation. If you'd like to come and see me, I'll be hiding over there on stand 44, and also more than welcome to provide you with additional information. And I don't want to take up too much additional time because I know we have other presenters on a similar theme to follow as well. But if there are any quick questions, be happy to answer. The question was, are there any interferences for tumour M2-PK? At the moment, there are none that have been known or are detected in terms of interferences for it. As I said, the cases where it may also be raised outside of colorectal cancer are primarily inflammatory bowel disease, and there is also some indication that in other situations with acute inflammation, so diabetic nephropathy, or in some patients with rheumatoid arthritis, that you might also potentially get an increase in tumour M2-PK levels. That, however, is more likely to apply with the EDTA plasma test, with the blood test, than it is for the stool test. The other thing, of course, is to be aware of, we did say that it needs to be a formed stool sample, so if you've got very watery stool, then potentially you get a dilution effect. Okay. The question was, with essentially moves potentially then on from guaiac FOB testing into other automated national screening program tests, as I understand correctly, where would tumour M2-PK fit into that? Is that correct? Yep. I mean, as an ELISA test, then actually this is a test that can be fully automated. The bit which can't be as easily automated is the very front end of that process in terms of the stool collection and then getting that stool into the extraction buffer. However, having said that, with the little quick prep devices, then that does minimise the amount of time that's required to do that step before running the test as an automated ELISA. Does that help towards your question? I think that one of the aspects that people have mentioned to me that they would like to look at, and in fact there's a couple of units that are looking at it at the moment, is in terms of how could potentially tumour M2-PK be combined with other colorectal cancer screening tests, so that ultimately overall you can have the correct patients being selected to go on for further invasive investigations. And that, of course, may save some costs in other parts of the service. Yeah, okay. All right. As I say, if anybody wants further information, and particularly once you've had a chance to let things mull through your mind, then I'll be over on stand 44, both today and for tomorrow as well. Okay, thank you very much indeed.